Hey guys, I'm Priyanka. I'm one of the third year residents. So today we're going to be talking about management of hypertension in the inpatient setting. But again, this is something that's going to chase us for the rest of our lives, irrespective of what specialty we are in, inpatient or outpatient. So we're going to go through some nuances and what kind of hypertensive crises are things that we commonly see in the inpatient setting and how to approach them. This is going to be a case-based presentation, so it would be great if it's interactive. I definitely want to hear answers from you guys. So let's start with the case. So we have a 36-year-old male who comes to the emergency room with a 4-day history of shortness of breath and chest pain. Given this history, what additional questions do you guys want to ask the patient?
To characterize the chest pain, and when did the shortness of breath and the chest pain start?
Okay.
Is the shortness of breath exertional, non-exertional, both?
I want to know if they're coughing, if there's more respiratory, or if it's more cardiac. So,
are there any specific questions you want to ask for that, Arpanji?
Yeah, so if it's cardiac, I want to know how long does the chest pain stay? Is it radiating, non-radiating? If they have any orthopnea, any paroxysmal nocturnal dyspnea, what's their functional status like? Any change in their recent exercise capability? And for respiratory, it would be more like cough, fever, chills.
Anyone else?
I don't know if you can read the chat. There are a few suggestions there as well.
Oh. Okay. So yeah, how many blocks can the patient walk? So yes, their exercise tolerance, any headaches, blurriness, or vision changes, okay? And whether it's pleuritic or not, right? So, and characterizing or asking more questions will help us characterize what exactly the symptoms related to, because chest pain and shortness of breath are pretty broad. It can be cardiac, it can be pulmonary, it can also be neither of those and a lot of other things. So when we asked the patient some pertinent questions in terms of the shortness of breath, he described it as being intermittent, worse with exertion, and also worse in the supine position. So basically that kind of elucidates towards your question about orthopnea. In terms of his chest pain, he said that it was a left-sided intermittent chest pain, but he told us that it was very unpredictable. Sometimes it was at rest, sometimes it was reproducible with exertion, and it was almost an 8 to 9 out of 10 in severity. It sometimes would wake him up in the middle of the night, and actually that was what prompted the visit to the ED. He had never had these symptoms before. And again, with chest pain, you kind of also want to assess the character of the pain, right? Is this like a squeezing or pressure-like sensation, which is something we commonly see in patients who have ACS, where they also do the Levine sign, where they'll like fold your hands as though their heart is being crushed. You can also have like a sharp pain, and this is something you will see in dissection. You can have a pleuritic pain that's worse with cough. So there are a lot of different causes for the chest pain. So in terms of his other review systems, these were the pertinent positive findings. Actually, I'm going to have someone read out the positive findings here. Bruno, your face is like the first thing I can see, so maybe I'm going to have you read.
No problem. So constitutional, the patient has fatigue. HENT, the patient has headache. For respiratory, patient has dyspnea. For cardio, chest pain and dyspnea. And for GU, the patient has intermittent hematuria.
Okay. So what other questions do you want to ask him?
How long has he been having hematuria for?
What medication is the patient using?
Were you saying something, Bruno?
So what medications is the patient using? And also Omar and Khalid said on the chat, to ask the patient about drug use.
Yep. So we asked him some more questions, and also it's again very important to not just ask them about their personal history, but also family history, because that can also give us some hints in terms of what's going on. So when we asked him these questions, he said that he's never had any other medical conditions. He denied any medication or over-the-counter supplement use. In terms of his past surgical history, he's never had any surgeries. The only pertinent family history was his grandfather, who was hypertensive. And in terms of social history, he said he's never smoked, he's never had alcohol, no recreational drug use. So let's go over to his physical exam. So when we initially saw him in the ED, his blood pressure was 213 systolics over 152 diastolics. This was measured in the left arm. And again, they repeated it on the other arm, and there was consistent or persistent elevation in the blood pressure. He was tachycardic, his heart rate was in the 110s, afebrile, not tachypneic, and maybe a little borderline with a respiratory rate of 23, but otherwise saturating 99% on room air. So in terms of the rest of his physical exam, there were really not that many positive findings, as you can see, that we've documented. Things, again, that you kind of want to look out for is, does he have any respiratory findings, right? Does he have any crackles on exam? Are you concerned for, with that degree of elevation in blood pressure and shortness of breath? Are you concerned for pulmonary congestion? Are you concerned for edema? So he didn't have any crackles on exam. His cardiovascular exam was normal. Again, with a young male that presents with hypertension, you want to check if there is any differential blood pressure across his arms or his legs, because again, that's something that will help us figure out what potential etiologies could be contributing to this. Again, you want to check for lower extremity swelling. You know, are there any signs of fluid overload? Because he also did give a history of orthopnea. So he did really had a fairly normal physical exam. So how, if somebody wants to give me like a problem representation or summary of this case?
I can try. This is a young male with no past medical history. It presents with 4-day history of dyspnea and exertion orthopnea and severe chest pain on his left side that wakes him up at night, found to be with the elevated blood pressure in the emergency department.
Okay. Yep, that was a good summary. Thanks, Galit. So, right. So, no 36-year-old male, no significant past medical surgical history, basically coming in with shortness of breath, intermittent left-sided chest pain, headaches, and hematuria, and vital signs significant for elevated blood pressure, tachycardia, but physical exam otherwise unremarkable. So, in terms of formulating a differential diagnosis, so say this is a patient you encountered in the ED, you're on night float, or this is an admission that you have to do. What are you thinking? What is going on with this patient? What are your possible differentials?
Hypertensive emergency.
Also, maybe a secondary cause of hypertension due to his young age and lack of significant family history, I guess.
I guess some sort of unifying thing that would cause the chest pain and hypertension, just in case if we think the hypertension isn't driving things. So like a dissection or STEMI, some sort of cardiac event.
Right. So what I'm hearing is basically he has some form of hypertensive crisis, which could be either primary or secondary to some underlying etiology. Again, one of the things that we should definitely not exclude or forget about is a toxidrome. Although patients might deny drug use, cocaine use can pretty much cause all of these things, right? So, all right. So let's talk about hypertension. So the ACC-AHA basically defines hypertension, and they define it in two different stages. So there's stage 1, where your systolics are between 130 to 139, or a diastolic between 80 to 89. And stage 2 is where your systolic is at least 140 or higher, and your diastolic is at least 90 or higher. Now, sometimes there's often a disparity, meaning your systolic values might lie somewhere within stage 1 and diastolics might lie somewhere within stage 2. In those cases, you would want to categorize the patient based on whichever category the higher reading falls in, right? So if your systolic is 132, but your diastolic is 90, the patient still has stage 2 hypertension. Normal blood pressure is obviously you expect a systolic less than 120 and a diastolic blood pressure of less than 80. And then there's this gray area where there are patients who don't really meet the diagnostic criteria for hypertension, but their blood pressure is elevated. And that is something we just call elevated blood pressure without a diagnosis of hypertension. Now, in terms of measurement of blood pressure, what we most commonly use in the hospital, it relies on what is called as the automated devices that we use here relies on an oscillometric measurement, right? There's the auscultatory technique that we use where we try to listen to the sounds with our stethoscope as we are measuring the blood pressure. What we use here in patient is the oscillometric method. Now, the problem with these devices is when your blood pressure is in a fairly normal range, these devices are accurate if you apply meticulous technique and use the proper ways of doing it. But when you start going towards extremes of blood pressure, and I don't mean necessarily just the high extremes, but also low extremes, they found that these devices have a lot of discrepancy with blood pressures that were measured using arterial lines. So whenever you have a situation where there is severe hypertension and you're concerned that there is some evidence of target organ damage, usually you need to use or place an intra-arterial catheter in those situations because you cannot rely on these oscillometric methods, no matter how accurately you do that. So in terms of the pathogenesis of hypertension, our blood pressure is essentially a product of our cardiac output and the total peripheral resistance. So anything that affects any of these factors can cause elevated blood pressure. So when we talk about cardiac output, it depends on your total blood volume in the body. It also depends on what your heart rate and what your cardiac contractility looks like. When you talk about vascular resistance, we have mediators that fall in two categories. We have vasoconstrictors and vasodilators. So common constrictors that we know of are angiotensin 2, catecholamines, leukotrienes, endothelin, and dilators include prostaglandins. The total peripheral resistance is also regulated by neural mediators, which is basically your alpha adrenergic and beta adrenergic receptors. And the alpha adrenergic receptors typically cause vasoconstriction, while the beta adrenergic receptors are dilators, sorry. So when we talk about hypertension, so we have what we call primary or essential hypertension. And this is something that we see in majority of our patients in majority of our population. So what are certain risk factors for this? So this is typically going to be an elderly patient. This is someone, if obesity can contribute to this or predispose you to essential hypertension. A strong family history of essential hypertension also puts you at risk. Again, race and ethnicity, this is something we commonly see in African-American patients or the Black population, and they can often have earlier presentation of hypertension. There are certain things like associated with like reduced adult nephron mass, and these could be either related to genetic factors or intrauterine developmental disturbances, dietary factors like high sodium diets, excessive alcohol consumption, or physical inactivity. When we talk about causes of secondary hypertension, there's literally a plethora of things that can cause this. And it's very important to kind of ask questions to make sure that your patient doesn't have any of the above things, because again, essential or primary hypertension is usually after you've excluded any secondary cause that might be contributing to it. This could be something as simple as over-the-counter medications, such as pseudoephedrine. You could have NSAIDs, and these are patients you'll see who typically have arthritis, back pain, taking a lot of Advil, coming to your clinic and have an elevated blood pressure. Also prescription medications. And again, these range from things like corticosteroids to like VEGF inhibitors such as bevacizumab and tacrolimus and other agents. We also want to think about aldosterone and adrenocortical tumors. So we're talking about primary aldosteronism, pheochromocytoma, Cushing's syndrome. We're talking about illicit drugs such as cocaine and methamphetamines, patients with either acute glomerular disease, including glomerulonephritis and chronic kidney disease, Renovascular hypertension, patients who have OSA typically will have elevated diastolic blood pressures and also are at a significant risk for pulmonary hypertension. You have patients with hypo as well as hyperthyroidism, patients who come in with like a thyroid storm. All these situations can also cause hypertension, hyperparathyroidism, and then you think about other rare causes like fibromuscular dysplasia and coarctation of aorta. So how do you approach a patient who has a significantly elevated blood pressure? So when you have a patient with a blood pressure, say his systolics are more than 180 and diastolics are more than 110 to 120, this again has to be reproducible on multiple measurements with an accurate device. It cannot just be one isolated reading. This has to be verified because this definitely affects how we manage patients. Now, the next thing that you want to look for is any evidence or any finding of acute target organ damage. And again, this step is extremely crucial because this changes disposition. If your patient has anything concerning for target organ damage, this includes a stroke, bleed, press syndrome, retinal findings like hemorrhages, exudates, or papilledema, again, something that we don't look for because we don't carry a fundoscope around with us. Any cardiac manifestations like acute coronary syndromes, acute decompensated heart failure, a dissection, acute kidney injury, or any abnormalities in the microvasculature, including microangiopathic hemolytic anemia, these patients need to go to a critical care unit. They cannot be managed on the floors. So knowing that is very important because that's going to determine where you send the patient. So if any of these findings are present, then you know that the patient goes to the ICU, and we'll talk about the management for that in a bit. If these findings are not present, you want to again confirm whether this blood pressure is still persistently elevated. So you advise 20 to 30 minutes of quiet rest, which again is very challenging in our ED. But ideally, you would want them to give them 30 minutes of quiet rest and recheck their blood pressure. Now, patients can often have symptoms related to the high blood pressure, but not necessarily have any evidence of target end organ damage. So what I'm trying to tell you is patients can have hypertensive urgency and still have symptoms. But this doesn't necessarily mean that they need to go to a critical care unit. In fact, these patients can definitely be managed with oral antihypertensives. They can either be managed in an inpatient setting, in an observation unit, and sometimes even in an ambulatory setting, as long as you can have close outpatient follow-up arranged for them. So again, this is kind of categorizing what hypertensive emergency and hypertensive urgency, what it was formerly called, or now it's just called asymptomatic markedly elevated blood pressure. So again, it gives you a criteria in terms of the blood pressure range. And the thing that differentiates the two is the presence of end organ dysfunction. Now, in terms of hypertensive urgency, what are symptoms that patients can present with? So they can have headaches, they can have epistaxis, shortness of breath, palpitations, lightheadedness, and nausea. And when you think about end organ damage, you're actually looking for certain specific things, right? So cardiopulmonary manifestations include myocardial ischemia and infarction. You could have acute left ventricular failure with pulmonary edema. You could have acute aortic dissection and unstable angina. And when you think about CNS findings, this could be encephalopathy, a bleed, a stroke, and you can have renal findings, which could include acute renal failure. So in terms of, this is just like, again, like a pictorial representation, if this sticks better in your head in terms of what are the manifestations for hypertensive emergencies. So in terms of lab abnormalities, now what are things you would want to check? What is the blood work that you want to get for this patient?
So I would say BNP, also urinalysis.
Mm-hmm.
Yeah, and people, okay. Let me read some of the chat. So
yep.
Rajan saying A1C, yeah, trope, UTOX, EKG, mm-hmm. chest X-ray, TSH,
yep.
thyroid panel, lipid panel.
Mm-hmm. Okay, so yes, most of your, basically what you guys told is, again, definitely some things are more time sensitive than others. So your troponin, your EKG, things that are going to tell you whether there's any evidence of end organ damage is definitely something you want to prioritize. And then obviously things like a lipid panel, hemoglobin A1C, all of this will be important when we are trying to figure out management and disposition, like what do we send this patient home on, like what's his risk for cardiovascular disease. So all of those things are definitely important, but again, less time sensitive, especially in this situation. So in terms of the blood work, this is what was positive. So does anyone want to kind of summarize what we got? What were the pertinent positives?
Only labs?
Mm-hmm.
Okay. So patient has thrombocytopenia, hypokalemia, a parallel AKI was creatinine 5.31, and elevated trope, elevated BNP, D-dimer, positive D-dimer, including hematuria, like gross hematuria.
Thanks, Louise. So based on these lab findings and with that clinical presentation, which hypertensive crises does our patient fall into?
People in the chat are saying hypertensive emergency.
Very good. And obviously there's one thing that particularly strikes out here, and that is his creatinine, right? So yes, he has elevated cardiac markers. Again, this could just be myocardial injury. Like we need to corroborate it with an EKG and obviously with the symptoms to see if this is an ACS or not. But more importantly, there's definitely one thing that's standing out. It was also reassuring to know that the tox screen was negative and there was no cocaine. So now, and the chest X-ray basically showed clear lung shadows and no evidence of like congestion or fluid. The next thing we also got for him was an EKG. Any budding cardiologist wants to interpret this?
I can try.
Mm-hmm.
So we see it tends to be a sinus rhythm. We see P waves mostly in D2. We see an approximate heart rate of like 120, like tachycardia, 130 maybe. Then narrow QRSs, we see the axis is likely like plus 30, like normal axis. And then we see very high voltages with a strange pattern, mostly on the lateral lead. As somebody was mentioning, they're most likely left ventricular hypertrophy pattern.
Yes. So yeah, definitely you can clearly see that the patient meets criteria for left ventricular hypertrophy. Again, there are different ways. You have the Cornell criteria, you have the Sokolow line criteria. So patient definitely meets criteria for LVH. And again, this is suggestive of long-standing hypertension. And that is what has caused that left ventricular strain and left ventricular hypertrophy, and corroborates with the findings on the EKG. Now, so we kind of established that our patient does have a hypertensive crisis and he has hypertensive emergency. Now, in terms of approaching a patient with hypertensive emergency, so again, the first and the most important thing is to establish that this is a true emergency. You need to evaluate for evidence of end organ damage, which we did with our investigations. Identify any precipitating factor. Again, like even hypertensive emergencies can be secondary to other etiologies. So anything that could be potentially contributing to this needs to be identified. And then you want to admit the patient to either a medical ICU or a CCU for close monitoring. Now, in terms of medical management of hypertensive emergencies, there are two basic things that we need to focus on, or two basic things that are important. What antihypertensive agent are you going to choose to manage this patient? And what is your goal for blood pressure reduction? Now, as a general rule, and we know this, we typically do not lower the blood pressure too quickly or too much. And this is because of chronic or sustained elevations in blood pressure, your vascular beds, because of autoregulation, are habituated to those higher levels of blood pressure. So if you drop your blood pressure too quick or too low, you can actually cause ischemic damage. So for most hypertensive emergencies, you want to reduce the blood pressure gradually. The usual target is about 10 to 20% in the first hour. And then over the next 23 hours, it's usually by 5 to 15%. So usually in the first hour, a target blood pressure of systolics less than 180 and a diastolic less than 120 is acceptable. And over the next 23 hours, you kind of want to get it less than 160 over 110. Now, in terms of medications, there are so you admit this patient to the ICU, you have to make sure you place an arterial line because, like we discussed, you cannot rely on oscillometric measurements. You need to titrate these medications very carefully based on what the blood pressure is. So A-line placement is crucial. And now when it comes to the choice of agents, this is actually a really useful chart because it tells you what intravenous agents are available, what is their onset and offset of action, and more importantly, what are their contraindications or where it warrants caution in terms of using these medications. So for example, if you see the first two medications, nicardipine and clevidipine, mostly they fall into the same category. They are calcium channel blockers. Again, clevidipine or Cleviprex is something that they also use pretty frequently in the neurosurgical ICU. Now, these medications have a very rapid onset and offset of action. But one thing you kind of want to remember with CCBs is it can cause reflex tachycardia. So you have to be very careful about its use in patients with acute coronary syndrome because you don't want to precipitate an ischemic event. The other thing with clevidipine, which is interesting, is that it can actually, it's prepared in a lipid emulsion, so it can cause elevation in triglyceride levels. And this is, again, something we see with another medication that we use in the unit, and that's propofol. So this kind of works in a similar way where the emulsion is basically lipemic. The next medication we talk about is labetalol. Again, this is something that we use pretty frequently, PO as well as IV in our inpatient settings. But again, this is to be used very, very carefully, especially if your patient is an acute decompensated heart failure, you're concerned about a bradycardia or heart block. And again, like with beta blockers, there is, in general, you have to be cautious, especially if there's concerns for cocaine use. Then we have the rest of these medications. And again, these are things you would commonly see being used. Nitroglycerine, nitroprusside is something that we commonly use in our units. Esmolol, metoprolol, and hydralazine, not so much. Not for hypertensive emergencies, at least. So again, just to keep in mind, what are the potential contraindications, things that you need to watch for. Again, the important thing about nitroprusside is cyanide toxicity. So again, these are things that you want to keep in your mind when you pick the kind of agent that you decide to administer. Now, in terms of treatment strategies for patients with hypertensive emergency, it's not really a one shoe fits all sizes kind of approach. You can't have the same blood pressure reduction goal for everyone. There are certain nuances to it. And I think this table really summarizes, it's a very good summary of what kind of target organ damage you're dealing with, what kind of agent you can use, and what is your goal for blood pressure reduction. So for example, in cases of, and I want to actually bring your attention to intracerebral hemorrhage and acute ischemic stroke. So if you see, like with bleeds, again, you want to decrease your systolic blood pressure to actually 140 to 150 millimeters mercury in the first hour. Again, this is, when you're thinking about like a large hematoma volume, there's evidence of raised ICP, so you need to have a pretty liberal blood pressure control. In terms of acute ischemic stroke, again, the goal for blood pressure reduction, again, depends on what is your intervention for the stroke. So if you are going to proceed with thrombolytic therapy, you want to decrease your blood pressure below 185 to 110 before you administer that thrombolytic agent. And then you want to maintain your blood pressure at a certain goal in the first 24 hours. So if there is no thrombolytic therapy indicated, there's no acute target end organ damage other than stroke, then your blood pressure goal, again, is a little more conservative. You don't need to drop it that fast. Again, for acute coronary syndromes and acute heart failure, if you see the systolic blood pressure goals are fairly tight, you want them to be less than 140. And then for aortic dissection, again, you have a very, very stringent blood pressure control, and you want your systolics to be less than 120. What I also like about this table is it gives you a very good summary of what agents you can use. So, as you can see, labetalol is actually first line in a lot of these cases or a lot of these end organ damages. And if I'm not mistaken, even when you read the stroke protocol that we do for our ACLS, it often recommends labetalol as one of the first line agents. When you go towards your ACS, acute heart failure, and dissection, again, for dissection, esmolol or labetalol is preferred. And then for ACS and heart failure, you have nitroglycerine, which is often used for initial management of blood pressure. And it also will help symptomatically to reduce your myocardial strain and help with symptoms like chest pain. So one of the interesting things that we saw in our patient was thrombocytopenia. Now, there is this whole entity where you have something called thrombotic microangiopathy in malignant hypertension. So what basically happens is in these patients, because of severely elevated blood pressure, there are certain autoregulatory or the compensatory mechanisms actually fail. So what this means is that there is an imbalance between your vasoconstrictors and your vasodilators. So your nitric oxide, prostacyclins, things that are going to dilate your blood vessels are actually low. And because of angiotensin II, there is increased production of pro-inflammatory cytokines. This causes endothelial damage. And whenever there's endothelial damage, it always activates a coagulation cascade. So what we see as a consequence of this is fibrinoid necrosis, edema of the arterioles, and also platelet aggregation. So when you have an arteriole that's narrowed by all of these factors, it can cause a shear stress and cause your RBCs to basically lyse. So you can see hemolysis. So that's why it's microangiopathic hemolytic anemia. But what's interesting is this also kind of sets up a ground for consumption of platelets, which is why you see thrombocytopenia. Now, if you have a patient who has hemolytic anemia, thrombocytopenia, acute renal failure, plus minus altered mental status, what is the other thing that you think about?
DIC.
What else?
TTP.
TTP HUS, excellent. And it's very important that we distinguish this because what is the management? How does it change management? What do you do if you suspect that your patient has TTP or HUS?
For TTP, you have to do like you have to remove the antibodies. I forgot the name from the top of my head.
So yeah, so you're talking about plasma exchange, right?
Yeah.
Yep. So again, so it's very important to differentiate this from TTP HUS because plasma exchange is key, and it's also a very time-sensitive intervention that needs to be done. So it's important that we rule out other causes. And the other thing that can be useful, again, this test takes forever to come back, but the Adams TS13 activity can be an adjunctive tool in differentiating if you are worried about that degree of overlap. But if this is a thrombotic microangiopathy that's exclusively because of hypertension, you will see that as you control the blood pressure and as time goes by, the platelet counts actually recover pretty well. And that's what we saw in our patient. So his platelet counts and his hemoglobin recovered as his blood pressure started to improve. He didn't need any transfusions or anything. It just spontaneously recovered. And that's because those compensatory mechanisms start kicking in again and as you lower the blood pressure. So in terms of hypertensive urgency, so now this is your patient who has asymptomatic elevation of his blood pressure, right? This is the patient you get paged about at night where the nurse will just drop in a note saying blood pressure 180/100 MD of air. So what do you do? What do you do in these cases?
Endorse to the 18th. No, you recheck. You first have to recheck the blood pressure.
Yep.
And there's multiple things like I see you put in there like pain and Also, like long-standing hypertension uncontrolled as an outpatient. Maybe the patient is admitted for a different reason and they have just uncontrolled blood pressure, but it's completely symptomatic.
Yep, very good. So again, the first thing is, again, important to check whether this is a true elevation or not. But there are like a lot of confounders. Like, how many times has it happened that the patient has elevated blood pressure? You walk in, this patient screaming at the nurse, right? So these are like anxiety, agitation, things like this are very common to elevate your blood pressure. So you need to address any confounders. So make sure the cuff size is accurate. And this is important for both hypo and hypertension. In your hypotensive patients, you have to make sure that the cuff is the right size because you don't want to underestimate or overestimate the blood pressure. And the same thing with hypertensive patients. Anxiety, agitation, and one of the most important things that we see especially in the inpatient setting is alcohol withdrawal. And that's something we definitely should keep in the back of our mind, because in those cases, the management is not addressing the blood pressure. Yes, that has to be taken care of at some point, but they need Ativan, they need Librium. So these are things that we need to think about before, directly resorting to treatment. Yes, let's give the patient IV labetalol, let's give the patient IV hydralazine, and that's unfortunately become a reflex. But again, trying to make sure that these things are taken care of, always making sure that you can let the nurse know, if the patient is asymptomatic, he looks comfortable, check the blood pressure, maybe do it in a different limb. But we need to make sure that this is a sustained elevation of blood pressure before we resort to treating it. Now, if none of these causes are present, you evaluated the patient, this patient is sitting very calmly, he has he's not retaining urine, he's not constipated, he's not in any pain. What is your preferred pharmacologic agent and what is your preferred route of administration? What have you guys been using on night float?
Hydralazine.
Hydralazine. And how are you giving it? I want to know how you're giving it.
It really depends, I guess, but
checking up to date. Checking up to date, yeah.
That's a start, yes. But when you put in the order, what do you usually put in? Is it PO? Is it IV? Is someone
IV.
using sublingual? I don't know.
IV.
IV, okay. Anyone else?
I guess you want to check if they're normally on something or if they were on something in the past, and then you can give them that if maybe they've just missed a dose.
Very good. Anyone else?
If they're on anything right now, and depending on the time, I may just give whatever blood pressure medication they're getting like an hour or two early.
Right. Okay. So yeah, I think Tyler and Joe, you guys both pointed out really good things. So we're not trying to reinvent the wheel here. If they have been on medications and for whatever reason the medication has been stopped in patient, we haven't ordered it, the next best thing to do is start them on that medication. But say this patient doesn't know what he's on, has not refilled his medications in over a year, you don't have a metric, what agent do you start him on? So it's very interesting because this is actually a study, and thanks to Jackie for sharing it with me. But they basically did this QI intervention at Sinai and it's called assess before treating. And their aim was to reduce the overtreatment of asymptomatic blood pressure elevation in the inpatient setting. So basically the QI, the intervention in the QI was more educational, educating the residents, educating the nurses, conducting huddles, and they wanted to reduce the amount of times IV antihypertensives were prescribed, or basically in the sense that you don't want to overtreat blood pressure or asymptomatic blood pressure. So if you see like the results or the conclusion part of it, so when they did the QI, the initiative actually did demonstrate a reduction in inappropriate use of IV antihypertensives and also an associated reduction in adverse events. And the main reason for this is because IV medications, especially IV antihypertensives, they can cause a lot of fluctuations in blood pressure. They can cause your blood pressure it's very erratic. They can cause your blood pressure to drop too low. So if you are not worried about any evidence of end organ damage, if this is just a patient who has an asymptomatic elevation in blood pressure, you ideally want to start with an oral agent. Now, in terms of what medications you can use, there's literally a number of different options. So, and again, it's important to know what your onset of action is, right? So if you have a patient who has your concern has an asymptomatic elevated blood pressure, you can try something like labetalol, you can try something like hydralazine, even lisinopril. And if you actually see their onset of action is not that bad, it's usually within an hour, and they last for fairly 12 to 24 hours. In terms of dosing, again, you can start low and escalate as needed. And you obviously want to be more careful, especially in elderly patients. Even with PO medications, our aim is to not drop their blood pressure overnight. You want to gradually reduce their blood pressure. The thing is, you have to be careful when using medications like amlodipine, because as you can see, it doesn't even kick in between 6 to 12 hours. So this is something that, again, you would use as a maintenance medication rather than something if you want more immediate results. So again, labetalol, hydralazine, nifedipine, lisinopril, all of these are really good options in patients who have an AKI, in patients who have CKD with an AKI on top of it. If you want to refrain from using ACE inhibitors, again, you have a lot of different choices. Hydralazine and nifedipine are very safe to use in those patients. But again, just be mindful that each of these medications does come with its own set of side effects. With labetalol, you want to watch out for bradycardia. Again, with hydralazine, it typically causes very erratic and unpredictable changes in blood pressure, and it also has the potential to cause reflex tachycardia. Again, with nifedipine, when we use the sustained release preparation, it's obviously a better alternative, and that's what you want to use versus the immediate release. And again, with lisinopril, you want to be careful that they don't have an AKI and what their potassium is. Again, just to reinforce what's written at the bottom, so IV agents are usually almost always reserved for hypertensive emergencies only. When you are suspecting hypertensive urgencies, again, you need to try and give them a trial of oral medications before resorting to IV formulations. So now, what are your next steps in terms of workup? So like all of you mentioned, this was a fairly young male with a family history of hypertension, but otherwise really no significant medical history. So you want to try and assess for any other causes or secondary causes and work up for them accordingly. So if you actually see this chart, again, this is something that's super useful. So you want to, the thing is, when you use your score calculators like your ASCVD risk calculator, all of it has been studied in patients between 40 to 75 years of age and not necessarily in the younger population. So you cannot really use those risk calculating tools for the younger population. And you always want to, before labeling them as essential hypertension, you want to make sure that there's nothing else going on. So things like your serum creatinine, your urine protein creatinine ratio, or microalbumin creatinine ratio, to quantify if they have proteinuria and if they do, how much of it. Your thyroid function tests, EKG and echo. And then again, you want to start thinking about, could this potentially be something endocrine? There was something on his labs that could have pointed towards a secondary cause. Did anyone point that? Did anyone make note of that?
Hypokalemia.
Oh. Right. So what are you thinking?
Hyperaldosteronism.
Yes. And again, that's something that's, when we study for our steps or, we're solving, this is a very classic vignette, right? This is a young patient who will present with difficult to control blood pressure, who presents with hypokalemia on his labs. And this also could be an initial presentation for hyperaldosteronism, right? It doesn't necessarily have to be someone who has had chronically elevated, difficult to manage blood pressure. So in terms of addressing or managing these patients, again, some of these tests can be done inpatient if the patient is being admitted for other reasons, but a lot of this workup can also be done outpatient. But some things that are unanimous, irrespective whether it's primary or secondary, is lifestyle modifications, right? If this patient is obese, weight loss, diet, exercise, and we know that there's that whole fancy table that will tell you, if you quit smoking, these many points, your blood pressure drops by. If you resort to a DASH diet, this is how it affects your blood pressure. If you lose 5 to 10% of your body weight, this is how it affects your blood pressure. And then again, you want to counsel them on the basis of that along those lines while working up for secondary causes. And in terms of your choice of medications, again, it depends. It depends on who your patient is, what their comorbidities are. ACE inhibitors, ARBs, beta blockers, these are things. Beta blockers not so often unless they have like other cardiac issues. And again, if you have African-American patients, you're thinking about CCBs, diuretics, things like that. So your target blood pressure goal in general in a patient should be less than 130/80. And this is something that is recommended for somebody with hypertension and cardiovascular disease, or with a 10-year ASCVD score of 10% or more. But again, like we discussed with hypertensive emergency, how dropping the blood pressure is not the same across all situations. Even with hypertension or essential hypertension or secondary hypertension, the blood pressure goal is actually varies with what kind of comorbidity you have. So for example, if you have someone with hypertension and CAD, again, you want to lower it to less than 130/80. And what are the agents that you can commonly use are your RAS blockers, beta blockers, with or without CCBs, and these are usually your first line agents. And in addition, you also want to use lipid lowering therapy, so high intensity or moderate intensity statin. In terms of hypertension and patients who've had a previous stroke, and this is a lot of our patients in the hospital, you again want to lower them to less than 130/80. You're trying to focus on antihypertensives along with lipid lowering agents. And again, antiplatelet treatment is something that's usually routinely recommended for ischemic stroke, but not so much for hemorrhagic stroke. Now, the next thing is patients who have hypertension and heart failure. So one of the things that you kind of see here is the agents, right? So angiotensin receptor neprilysin inhibitors, or they're also called as ARNIs, or Entresto, is something that we actually use for patients who have heart failure. And it's a very good agent because it also helps you control the blood pressure. And then when you come to hypertension and chronic kidney disease, again, you still want to use RAS inhibitors because they do reduce albuminuria in addition to blood pressure control. So they do have a nephroprotective effect. Again, CCBs, loop diuretics. And again, in these patients with diuretics, they often have a higher threshold. So you might need a higher dose of diuretics to achieve good control. So there are certain like key recommendations to practice. Most of these are like the evidence rating is C, but just some things to kind of keep in mind are, again, in young patients, especially if they have resistant blood pressure, you need to work up for secondary causes. In patients who you suspect can have hyperaldosteronism, you want to obtain the plasma aldosterone plasma renin ratio because you want to calculate the aldosterone renin ratio, and that's going to help determine what the cause is. Again, do not underestimate common things such as OSA, which can be a very important cause of hypertension too. Now, there are certain signs and symptoms, again, that you can look for that will suggest specific causes. So if you have a differential blood pressure in your arm to, like if your arm to leg systolic blood pressure difference is more than 20, you're thinking about things like coarctation. Again, renal artery stenosis. This is something, again, very classic where you see an increase in serum creatinine after starting an ACE or an ARB. Again, if patients have any signs of hypo or hyperthyroidism, you want to work them up for that. Hypokalemia can point towards aldosteronism. OSA, you can have patients who have a history of snoring, apneic events at night, daytime sleepiness. Pheochromocytoma is again another one, an endocrine tumor. Again, we don't see it that commonly, but you can have patients who have labile blood pressures with these headaches and palpitations. Cushing's syndrome, and again, this is something you need to keep in mind. This could be either secondary to a tumor or it could be secondary to long-term corticosteroid use. So you will have all these signs, the buffalo hump, the central obesity. Often patients have uncontrolled or poorly controlled diabetes. So hyperglycemia can be another thing associated with that. So just coming to the take-home points before we wrap this session up. So acute severe hypertension with end organ damage, that is hypertensive emergency. Admit to an intensive care unit, you need an arterial line, you need intravenous agents. The choice of the agents and the blood pressure reduction goal depends on what kind of target organ damage you're looking at. When they did certain studies, they found that non-adherence to previously prescribed antihypertensive medications was the most common factor leading to acute severe hypertension. So before we start thinking about the zebras, the first thing we need to ask a patient is, have you been taking your medications or not? Chronic hypertension, again, you want to think about how it affects your autoregulation in different systems. And especially we are worried about the brain, because if we drop the blood pressure too low or too fast, we can induce ischemia and you can have watershed infarcts. So you need to be very careful about how much you're reducing your blood pressure by. Again, hypertensive emergencies, they have to be managed with intravenous medications, while urgencies can be managed with oral medications, and then you can have patients follow up in the outpatient setting. So I think that was it. Please let me know if you guys have any questions.
I have a quick question regarding hypertensive urgencies on the floor. Which one is your threshold to treat?
So, I mean, I think that if you're so ideally, again, you want your patient's blood pressure to be less, ideally, you want it to be less than 130 to 180, 130 over 80. But if you have a patient that has, so I think your reflex initially would be to just resume home antihypertensives, especially if they're taking that. If the patient is not on any hypertensive medications, I think usually when you have a sustained elevation of blood pressure with systolics more than 180 or diastolics more than 90 to 100, I think at that point in time, you should consider giving them at least some sort of PO medication and seeing how their blood pressure responds to that.
Yeah, because like sometimes happens when you're on night, like nurses text you, oh, blood pressure 160 over 80, which is high, but I guess it's not that high for you to like acutely do something. So I was wondering, like, so 180 over 90.
Yeah. And usually, again, you want to look at the trend, right? For example, if you check at this moment and it's 160 over 80 and say the nurse checks it after 2 hours and the blood pressure is either stable or coming down, then I wouldn't be as inclined to treat unless I figure out what exactly is going on with the patient. But if you're talking about blood pressure that's actually starting to go higher, I think that is somewhere you would want to intervene. So I think it's more not just about what's in that moment, but more about what the trend looks like, which would affect your decision to treat the patient.
Thank you.
Thanks for the presentation, Priyanka. I have a question about, so in the ED, sometimes we see that those patients with high blood pressure that have only headache as a symptom, what would be the threshold for those patients with an isolated headache when I have no focal signs to get a CT scan, for example?
So we'll discuss realistically and we'll discuss what actually happens, right? So what actually happens is most of the times your patient will have a CAT scan. So did this guy, just saying, just putting it out there. But again, like if you want to assess, again, these patients usually need slightly closer monitoring. So again, the headache might just resolve as their blood pressure comes down. So what I would say is if you are administering an antihypertensive agent, you want to make sure that within an hour or two, you reassess not just the blood pressure, but the symptoms as well, right? If there is, obviously, if there's any concerns for any acute focal neurologic deficit, altered mental status, vision changes, then all of these situations, I think it's very important to get a CAT scan of the head. But I think in a patient who is, for example, in this guy, right? He was 37, he was young. The only complaint was headache. He was sitting, answering all questions appropriately, really not having any issues. I wouldn't be inclined to scan this patient because let's think about it this way. If this patient came to you in clinic at Ryan with a blood pressure of 170 over 80, would you scan him if he complained of headache? Right? So it's the same thing. Their choice to come to the ED doesn't need to affect our choice to do something, right? Because at the end of the day, what we determine is also has to be based on some sort of clinical evidence. So if we think that there is any concern that there might be a bleed, say his headache is worsening, like those are things that are concerning. So I think it's very important to reevaluate those symptoms rather than just looking at it as an initial presentation or as an initial finding and seeing how they respond to treatment, and that can determine whether or not you want to do imaging.
Great, thank you.